Hello and welcome back to the channel. My name's Dr. James Gill and you've joined me with a slightly rusty throat today. Now, I've been very clear that the knee joint is my favourite joint. It's fantastically mobile and from an anatomy perspective it's very interesting. Particularly because that anatomy can mean that patients can have knee pain that isn't directly as a result of the problem with the hinge. Today we're going to look at two conditions that affect the knee, that of patellofemoral pain syndrome and iliotibial band syndrome. When we're talking about syndromes, you know there's going to be detail here. So with that in mind, bear with me here, there's many jobs, particularly as an NHS employee, where we have to do mandatory training. And some of it's like how to sit at a desk, which at first glance can be a pain in the neck because we all know how to sit in chairs. But give me a moment before you change the channel, because actually here's an example of how these modules, as annoying as they might be, may actually be beneficial, and thus why some of the advice on how to sit on a chair might be beneficial. So with that in mind, let's get one thing clear. Myopia is not caused by use of screens. However, there is evidence to support that prolonged screen use might increase the risk of myopic short-sighted progression. To this end, one of the solutions put out with these modules is the 20-20-20 rule for screen use. Every 20 minutes, take a 20-second break and make sure you're looking at least 20 feet away. The concept here is that prolonged focusing on near objects, such as a screen, can have an impact on the eye's ability to change the lens to focus on distant objects. So when we look at far away objects, the lens has to thin and flatten, which is done by the muscles, the ciliary muscles relaxing and the suspensory ligaments tightening and stretching that lens. Kind of like you could with a balloon that's deflated. You pull it in, it becomes thinner and flatter. The problem is constantly focusing on near objects or accommodation causes strain to these ciliary muscles, which can lead to fatigue, spasms, and thus temporary issues with regard to focusing. Now, this isn't directly causing myopia, but it is having an effect because the overuse can cause a pseudomyopia, a chronic strain where the muscles spasm mean they can't fully relax. That means the lens can't be fully pulled flat, and we can't focus properly at a distance. Now, the same is also true. Presbyopia, I can never say that word, or long-sightedness, this is due to lens aging normally and a reduction in that elasticity. However, if we're having a lot of screen use time, as the ciliary muscles fatigue, they've also got a reduced efficiency, meaning that when they're pulling on the lens, which is needed to make it fat and thick to accommodate, to look at close things, they're not able to do that. So what these modules do is, give you an idea of how you can actually protect yourself from work. And we'll talk about how that relates to the knee pain. You did realise this was going to be a knee pain video. He says, talking about eye stuff. The point is that ergonomics with regard to your desk and things, while often delivered in a less than ideal and engaging manner, can be beneficial. So let's actually do that. Let's focus on the knee now and how the effects of prolonged sitting, as believe it or not, but Mother Nature didn't intend for us to sit at a desk for 4 hours, run off, grab a sandwich and then return to sitting at our desk for another 4 hours. That wasn't in our design plan. So as a consequence of sitting down for prolonged periods, we can actually end up with a patellofemoral pain syndrome, where there is an interaction between the patella and the femur causing pain. So let's take a look at the knee and what happens when we sit down, and that should explain it. When sitting, the knee is at 90 degrees of flexion and the patella, the kneecap, gets pressed into the femoral groove here. This compression of the patella into the femoral groove in some people can lead to excess problems with pain. You see, the longer you sit, the greater the lack of movement there is with the knee. And that kind of makes sense because we know that the movement impairs the flow of synovial fluid within the knee, which itself is the life-sustaining fluid that moves nutrients and oxygen around the knee to the cartilage. That lack of movement further will lead to tightening of the muscles and potentially exacerbating other muscle issues, and then lead to joint stiffness. Keeping in mind, stiffness, medically speaking, simply means reduction in the movement range of a joint. Now, it's important to note, if a patient does have tight muscles, they may have shortened sufficiently to impact on the maximum range of the joint, i.e. sitting, causing muscle shortening, can result in stiffness. Now, it is a fallacy to say that sitting leads to injury. However, sitting does provide the circumstances for maltracking, muscle imbalance and patellar compression, all of which can lead to pain. So that's the kind of thing we're looking to avoid. So let's take that information and apply it to patellar pain syndrome, but also iliotibial band syndrome, where we can get pain on the outside and hopefully help you distinguish between the two, because these are both syndromes and they are both often confused from a patient perspective, because it's all very much a pain without radiological findings. So let's start with patellofemoral pain syndrome. Cunningly named because it's an issue between the patella interfacing with the femoral condyles. The patella glides within a groove at the end of the femur as it's flexed and extended, with the patella acting as a pulley for the quadriceps muscles, increasing their mechanical advantage in terms of movement of the lower leg. Basically, your patella allows you to kick a football with more force, as it were. And I think that's one of the things that we can often forget about the patella, that we use it to generate more force rather than just focusing on the quads to generate that force. So given this, it's not unsurprising that we've got a problem with pressure against the patella, that we're dealing with pain around the knee but also behind it, hence why iliotibial band syndrome, which tends to cause pain around the knee and to the side, can get confused. You see, the problem with both of them is that we're not dealing with a single structure or tissue that's the problem. It's a combination of issues with maltracking, problems with joint stress and irritation of the soft tissues. So given that overview for patellofemoral pain syndrome, let's have a look at iliotibial band syndrome. Here, it's more of a problem with the knee hinge as opposed to movement of the patella, because we're not dealing so much with the power transfer issue. So the iliotibial band, or the IT band, is a thick band of connective tissue that runs from the iliac crest of the pelvis down to the outer thigh and inserts into the lateral tibial condyle at a point called Gerdy's tubercle, along with a series of connective secondary points that are attaching into the patella, as you can see here. We've sort of got almost an anastomosis, and everything becomes quite vague down here. As the knee flexes and extends, the ITB tension will shift, and it gives an impression of movement over this region, but it's not actually changing in position, it's just a change in tension. So it's sort of a pseudo change. So with the ITB band, we're dealing with a tissue that both crosses the knee, but is also, with regard to the muscles in the hip here, is actually involved in movement of the knee itself, but will also move in relation to the knee joint. Hence, pinning down iliotibial band syndrome can be a challenge. But in my mind, the main indicator is the pain on the outside of the knee, as opposed to around or behind the patella that we'd see with patellofemoral pain syndrome. So we understand that the patellofemoral pain is more associated with the bone, whereas ITB is more associated with the soft tissues. So it's all well and good saying that it's an ITB problem and it's a patella problem, but how do these pain issues come about? So when we're talking about patellofemoral pain syndrome, anything where you're doing deep knee bending, like squats or stairs or sitting for a long period of time with your knees bent, heck, if you're just sort of sitting with them crossed under your body, that's going to vastly increase the pressure between the patella and the femur, causing increased levels of pain. Mechanically, weakness or poor control of the quadriceps, particularly vastus medius oblique, can mean the patella can shift slightly off track, taking a different route between the femoral condyles, again causing pain. We can see that if we bring the knee in here. If, for example, we've got the one muscle pulling it out of alignment, that patella will come out of the groove and can end up rubbing in an area where it doesn't have the design for, because it's not flat, it actually is slightly pyramid shaped to fit into this groove. With regard to the maltracking, this can be worsened if there's tightness over the iliotibial band, problems with the flexors or the lateral retinaculum. They can end up pulling the patella laterally, which can again actually cause pain on the outside lateral aspect of the knee, which can confuse the diagnosis, because then, although we're dealing with a patella maltracking due to patellofemoral pain syndrome, it actually seems to be mimicking the area of pain that we'd see with iliotibial band issues. Finally, just issues with the kinetic chain. We've said it before, the hip, the knee and the ankle all need to be in alignment. If they're not, again, that can pull the patella out of its groove and affecting the symptoms that we're having. So everything that we're looking at with patellofemoral pain can be summed up as either a problem with tightness or a problem with weakness, both of which can be exacerbated by poor ergonomics in a patient's workplace. Can you see how everything's connecting here? So, with that in mind, let's contrast this with iliotibial band syndrome. So now let's contrast that patellofemoral pain syndrome with iliotibial band syndrome. Here, repetitive flexion and extension, such as long distance walking, running or cycling, aggravates this friction point over the femoral epicondyle. So as we've gone from patellofemoral pain issues with deep bending and pressure against the condyles, here we're actually going for like a tissue irritation as opposed to a pain. Weak hip stabilizers such as gluteus medius and its associated tissues can let the femur internally rotate excessively during activity, which can give the effect of heightening ITB band tension. You could describe ITB as an overuse injury, except inactivity can inactivate the gluteal muscles, which combined with muscle weakness from sitting can actually increase this internal rotation and increase the pain that you get from it. The body's always going to try and remain in balance. Therefore, in response to excessive internal rotation, the tensor fasciae lata on the outside of the pelvis can chronically activate, resulting in its shortening, which, as you can see here, can end up putting increased pressure or tension onto the iliotibial band, which may in turn end up affecting patella maltracking. So again, you can see how the two can be confused. So I've mentioned that seating or prolonged sitting can be a problem for both of these. Why? Well, when you sit at 90 degrees, as mentioned, the contact between the patella and the femur increases. So for someone with patellofemoral pain syndrome, the longer you fit, the more likely you're going to feel a discomfort. That's why patellofemoral pain syndrome can also be called the moviegoer's knee, which is ironic because it's also called the runner's knee. Now, let me be clear, that's not to say that runners can't be moviegoers. I'm a big fan of going to the cinema and I quite like a 10k run. But the point is, the two sit together. Regardless of the name, we're still dealing with a pressure issue here. When seated, the knee's held in a flexed position, increasing that patellofemoral surface load. And crucially, the longer you sit without the movement, you're going to get a greater level of discomfort. Very specifically, sat with your knee at 90 degrees causing pain is also called the theatre sign. And that's important because we see it in another condition called chondromalacia, where the underside of the patella, the cartilage there, has become irritated and maybe softened, again causing discomfort with overuse and, as we get the knee at 90 degrees, we would also see with chondromalacia increased pain there. The crucial thing to separate patellofemoral pain syndrome from chondromalacia is chondromalacia can be seen radiographically. You can see it on imaging, or if you did a scope to the knee, you'd see this irritation to the patella and the cartilage there, which is not something you see with patellofemoral pain syndrome. Whilst it's important that we note that sitting doesn't directly irritate the ITB band at the knee, because there's actually minimal movement or friction, it's the underlying factors that will lead to discomfort. So sitting will indirectly worsen ITBS by shortening the hip flexors and the tensor fasciae latae, both of which are going to connect into the iliotibial band. So prolonged sitting with poor posture without breaks over time is going to increase the baseline tension at the ITB, which will manifest as increased friction and can often lead to pain when running or possibly even just walking. The hip position also plays a role in iliotibial band syndrome. Sitting with your hips adducted, your knees pushed together, will further tighten the iliotibial band and stretch out the gluteal muscles, reducing their stability once you're upright, hence tensor fasciae latae recruitment that we've spoken about a moment or two ago. When physiotherapists and orthopedics talk about biomechanics, they're literally meaning the body's mechanics of movement, which, as I think you're beginning to see, is essential when we're dealing with pain problems. To recap, prolonged sitting alters the muscle balance around both the hip and the knee. Hip flexors like the iliopsoas and tensor fasciae latae become tight and shortened. Gluteus maximus and medius are going to become inhibited and weakened. The hamstrings can become tight, while the quadriceps can lose tone and coordination. So given these muscle changes, with patellofemoral pain syndrome, these changes can result in poor control of the patella, causing the knee to cave inwards, potentially causing maltracking worsening. And that can actually be visible sometimes when a patient's entering the room. By comparison, with iliotibial band syndrome, we've got a tight tensor fasciae latae and weak gluteus medius are going to increase tension in the ITB, making it more likely to rub on the lateral aspect of the knee. What I really want to make clear here is that sitting isn't just a passive issue, where we're concerned about like a calorie burn and things like that. This inactivity will subtly reshape the muscle balance in your legs and set up a risk for you for these pain syndromes. So if you've got issues that you think might be related to your work environment, have a conversation with your occupational health team. They're probably going to give you some very practical strategies about how you can optimize your workplace to mitigate some of these strategies. And if you don't have an occupational health team, speak to a physio. They can give you simple advice like this. And I think that's got to be the question. Once we've got ITB and ITBS, what can we do to improve it? So before we go any further, I'd like to highlight that this is a sponsored post by Libonovo, who've recently brought out a new chair, the Omni, which is available on Kickstarter now. Now, being perfectly frank, because I have issues with patellofemoral pain syndrome and I see issues with patients' knees quite a lot, this was a video that I was planning on doing anyway. And the fact that they put forward this sponsorship offer seemed to align very well. The thing that surprised me about this chair, and again with the full understanding that it's a sponsored post, is it's actually really, really flexible. As a doctor, I have a very good ergonomic chair anyway. This is equally comparable to a lot of the certified chairs in terms of comfort that we use at work and things like that. I actually think that mobility with regard to chairs is something that we need to put more weight on, as in, does the patient or does the user feel comfortable in actually moving around in the chair? The BMJ in 2020 had a very interesting study showing that 73% of a worker's time is spent sat down, and that there are many options with regard to standing desks and active strategies. They do all have a benefit with regard to getting the patient moving again, even if those are chair-based activities. That to me says that there is an activity problem with regard to being sat down at work. We know that, this is part of what we're talking about with regard to patellofemoral pain syndrome. There was a further study by Yiding et al., and I think that was 2022. They found some very interesting information with regard to active intervention. So they studied the muscle fatigue or the muscle electrical activity using electromyographs. And what they found was that after about 40 minutes of sitting, the muscles essentially switch off. And they then looked at a series of interventions, so standing up and going for a walk, standing and stretching, or chair-based activity, stopping the work that the patient was doing. Interestingly enough, because I thought the going for a walk would have been the most effective, the actual standing and stretching had the biggest impact on returning the muscle tone to normal, which then would degrade over the following 40 minutes of being sat inactive. The reason why I bring that up is that the Omnichair has a button. Yes, this thing has a battery pack, and who would have thought we would be living in a world where we needed to charge our office chairs, but it does so. The point with this button is it actually has a series of motors behind that can allow you to stretch whilst in the chair. And frankly, I've been surprised at the level of movement you're going to get from it. So if you are in the market for an office chair, if you're in the market to change up your things, have a look at the Omnichair, which is available on Kickstarter now. So back to the video. So given we understand what causes the problem with patellofemoral pain syndrome and ITBS, it makes sense that the management is going to be trying to mitigate those factors in the first place. So what are the conservative changes? So simple things that can be applied immediately would be the first step, and they're mainly about optimizing position to mitigate issues with pressure and fatigue. With patellofemoral pain syndrome, we want to reduce this pressure at the patella. So where possible, we'd recommend that patients who must sit for long periods of time position their knees greater than 90 degrees, because that is likely to reduce the compression. So at 90 degrees, we can see there's plenty of compression there, and when we open it up, that pressure reduces. That does seem straightforward, but just think how often it is you sit down in a chair and immediately put your knees at 90 degrees, or maybe even stick your feet under the chair. I can be intermittently affected by patellofemoral pain syndrome, and where possible, I will actually try and keep my leg extended to try and get the patella away from the pressure in that groove. You see, the thing is, the body is always in balance. So as well as focusing on the knee, we can also look at the hips, adding a degree of anterior pelvic tilt to the seat base, so increasing the lumbar lordosis, and placing the hips higher than the knees. That will improve pelvis rotation and hip position, all of which will act to lengthen the rectus femoris muscle and improve some of this discomfort here. So by trying to make things easier, we're trying to change habits. If we're trying to encourage keeping your knees at greater than 90 degrees, it makes sense that pushing your knees more than that are going to be a problem. So that will be suggesting that people have their seat as high as they can, making sure that you're not bending down or putting a lot of pressure on your knees directly. And if you do spend some time bending down at work, think about having cushions and things, pads that will reduce that pressure, or at least spread it around. Now, I appreciate those are all relatively easy, passive approaches. If we want to be a little bit more active, then we can move towards stretches and muscle strengthening. So when we've been sitting for, say, 30, 40 minutes, pause, get up and try and stretch the quads. Now that's relatively easy to do, even in a work setting. You can stand up, take your foot, and then just sort of bending forward, trying to get that strain over the quads. Even as little as 20 seconds can be beneficial. Other stretches that would be worthwhile targeting the hip flexors and definitely stretching out tension fascia lata, but both of these need the patient to be lying down in order to be able to do those effectively. Now, it is worthwhile highlighting that the iliotibial band can't actually be stretched, so foam rolling is not going to have a direct impact here because it's such a dense fibrous tissue. However, again, focusing with the foam roller to the gluteal muscle and perhaps tension fascia lata could provide benefits from a neurological integration perspective, maybe reducing tension here and again easing off ITB band. As a final suggestion, we can also look at muscle strengthening. In patellofemoral pain syndrome, that's going to be directed more towards the quads because we want to try and reduce or realign that patellomal tracking. By comparison, with regard to ITB, that muscle strengthening work is very much focused towards the hip flexors and the gluteal muscles, all of it trying to stabilize the hip, reduce that excess internal rotation and try to take off tension from the hip. With all of these things, I would, with regard to stretches and strengthening exercises, whilst it's useful to have an idea what we might want to do, I really can't stress enough that this is something you should really want to get involved with a physiotherapist so that they can make sure that you've got the correct recommendation and that they're being applied appropriately. The simple posture-based changes I think are reasonable for anybody to do themselves, or even better, as I say, engage with the occupational department. But from a physiotherapy perspective, I would strongly recommend that you get a professional to help you, at least initially, guide you with those stretches and the strengthening activities. So there we have it, the pathology and pathological features of iliotibial band syndrome and patellofemoral pain syndrome. And hopefully you can see how these relatively simple conditions can cause a lot of pain, but also can be due to regular day-to-day inactivity. So I think if nothing else, the take-home message has got to be, think about your biomechanics if you're having pain or if you've got patients that are having pain and problems with the knee. As a rule of thumb, unless I've got an x-ray showing horrendous arthritis with regard to a patient's joints, I'm almost universally going to recommend that they see a physiotherapist to see what can be done with regard to stretches and muscle strengthening to improve the pain or the symptoms that a patient is experiencing. And crucially, that is patient education. When they understand how to do the stretches and the strengthening, that means that they can do it themselves. You're providing the patient a way to help themselves and empowering the patient to change the natural course of their condition, particularly where, as I say, we can do baseline things, changing seating positions, example. So I hope that's been a useful video. My apologies for the voice, but hopefully you've seen that patellofemoral pain syndrome is a significant problem, but actually is something that hopefully with a bit of careful assessment can be changed and improved. Take care and we'll see you in the next one. Cheerio.